This 2025 review doesn't try to prove whether intracellular bacterial communities exist. It asks whether we finally have enough evidence to treat patients as if they do. This is an invited review from the ICIRS research meeting, the International Consultation on Incontinence Research Society. This paper asks the questions we really need answers to in this community. Not whether recurrent UTIs exist, but whether our current understanding of biology justifies targeted bladder treatments. The authors reviewed human and animal data about intracellular bacterial communities, or IBCs, urinary microbiome literature, chronic UTI diagnostic, antibiotics distilled directly into the bladder via a catheter, gag layer replacement. This is a direct instillation therapy aiming to improve the bladder's protective lining, and bladder electrofulguration. This uses electrical currents to destroy abnormal bladder tissue. This paper was structured as an expert think tank and not as a trial. Asking the right questions is really important, and here are the ones that the paper asks. Can we define a normal urinary tract microbiome and compare this to the microbiology found in those with recurrent or chronic UTIs? What is the definition of a chronic UTI, and is there a reliable biomarker to aid with the diagnosis of this? What is the role of IBCs in recurrent or chronic UTIs? What is the efficacy and optimum treatment schedule of bladder installations? And is bladder electrofulguration an effective treatment for those with recurrent or chronic UTIs? They end up with 4 key points. They say that direct visualization of IBCs in human bladder tissue is still unproven. And although this point is made, it is important to say that this has been shown. Check out our interview with Dr. Harry Horsley below. They do go on to say that bacteria are consistently detected within the bladder wall using technique FISH. They conclude that urine cultures and dipsticks are systematically underdiagnosing infection, and that installations and fulgurations show promise, but evidence quality remains low. This paper formally recognizes chronic UTI as biologically different to acute UTI, acknowledges immune invasion and residual tissue bacteria, and confirms that second-line bladder-directed therapies are no longer fringe, they are just insufficiently validated.